Welcome to this session, the Interplay of Tobacco Control and Broader Health Agenda. It's not going to be exactly as broad as we would have hoped, as several of our speakers are not here for various reasons. We have only 3 speakers here, so the session will be a little shorter than usual, but we'll have more time for questions at least. I'm Jonathan Golub. I'm from Johns Hopkins University. And I do tobacco research in HIV and TB primarily, but was asked to do this section as we have several tobacco sessions at this meeting, which it's been nice to see this year on various issues. And I'm here co-chairing with Hassan Latif from the United Kingdom, and he will take the lead in introducing some of the 3 speakers that we have.
Thanks, Jonathan, and I'm Essen, and I work for the International Union Against Tuberculosis based here in the UK. So our first speaker is Tanya Cavalcanti from Brazil. Tanya leads the tobacco control efforts from CONADIC in Brazil. She has a long history of tobacco control. She has been pioneering the work on FCTC, and she was just telling me this morning they are awaiting a big judgment on additives in Brazil. So we hope that it goes Brazil's way, and the industry loses again as it is supposed to lose. So over to Tanya.
Good morning for everyone, and I'd like to once more thanks to express our gratitude to Union to invite us to share our experience, lessons learned, and our difficulties. And today we are going to talk on how Brazil has dealt with the merging FCTC implementation into the NCD agenda in Brazil. So we are going to talk, sorry, it's not working. No, it's not working. Okay. So we are going to talk a little on the governance of tobacco control policy before and after WHO FCTC negotiation, ratification, and how after this process, WHO FCTC makes interface with NCD program in Brazil. And we are going to show a little on how WHO FCTC brought some important outputs for NCD's mortality in Brazil. So a little of this history in Brazil. Since 1989, the National Cancer Institute of Brazil assumed the role to coordinate the National Tobacco Control Program in a momentum that this issue of tobacco were not part of the health agenda. It was very difficult to put this in the agenda because tobacco use, smoking in Brazil in that time was seen as a lifestyle, not a problem, a health problem. It was very difficult. So in this gap of including this item in health agenda, National Cancer Institute assumed this role and put this tobacco control as part of the National Cancer Control Policy that's under the management of the National Cancer Institute, the place where I work in Brazil. The National Cancer Institute is a branch of the Ministry of Health in Brazil. So in the beginning of the 90s, our job was to put some people on board of this difficult process. We tried to catch people from the state health offices. We have 26 states and 1 federal district in Brasilia. So we tried to identify focal points and to start to build capacity buildings and to share the information on tobacco use and things like that. And we succeed to put some financial resource in these secretariats in order to put this item in the health agenda, in the national health agenda. It was a process very long, but in short terms, it's this. Just another example that it was very important to bring some other people or some other institution on board of this process. In 1996, a study from the National Cancer Institute started, this is the media output on this research that INCA has done. This study, this research showed that the tobacco industry used to put ammonia in the cigarettes in order to increase the capacity of cigarettes to cause nicotine dependence. So this was there was a scandal in Brazil. It was published in the main communication vehicles in Brazil. Veja is one of them. It was the front page of this magazine. And the result was that when the National Sanitary Surveillance Agency was created in 1999, the Ministry of Health negotiated to put under the responsibility of Anvisa the tobacco products regulation. So this was a result of this process. So now we have much more in this momentum. In 1999, we have the network of health offices in 27 states and municipalities. We have now the Anvisa on board of this process. And in 2000, we started to try to cross-cut tobacco control in a different health agenda: women health, aging health, child health, and so this was our main job in 2000, the year 2000. And finally, in 1999, when FCTC started to be negotiated, in Brazil was created a national commission, a multi-sectorial commission to advise the government in this negotiation process, because the agenda of negotiation was much more than health action. We saw that we had to negotiate some taxations, everything that would be needed to implement FCTC. So in 1999, it was created this national commission that helped us to negotiate FCTC. And after FCTC negotiation, the National Commission, that you can see the one, was substituted by the National Commission for FCTC implementation in Brazil. But this commission, when we ratified, it's very important to say that we had an upgrade on our tobacco control program. This National Tobacco Control Program became a national policy on tobacco control, a state policy. We always repeat, this is not a government policy, this is a state policy. It means that any government that comes on board has to comply with it. So this was very important for us. And you can say that this is over parties of the government. So it's very important. That former commission that was created to advise the negotiation process was substituted by a national commission, now with the responsibility of ratifying, promoting the ratification, as well the implementation of FCTC. It was not only anymore only an advisory board, but an executive board. So this is the mandate of this national commission. And today, this national commission is formed by 18 different sectors of the government. We have the Minister of Health himself as chair in this national commission. And the National Cancer Institute has the role of executive secretariat of this commission, and the director, general director of National Cancer Institute is the co-chair of this commission. So now we have this complexity. The governance of tobacco control policy in Brazil is not only one institution. We have several institutions. We have Fiocruz, that's a very strong institution. We have several universities. So we have a connection with these different groups that help us to face the tobacco industry interference, opposition. So this is we have a very strong network working toward the same direction, FCTC implementation, FCTC enhancement in Brazil. In 2010, the Minister of Health, mobilized by the UN agenda, high-level UN agenda to tackle NCD disease, decided to prepare a national plan to tackle non-communicable disease. It was very important because that network that has already been working with tobacco control in Brazil strongly participate in this process with other sectors, with other institutions. We succeed to put them on board to put tobacco control in this agenda. And the result was that the implementation of FCTC was totally included as part of health promotion axis of this plan. And it includes all FCTC measures, including the Article 6, Article 8 that deals with secondhand smoke, Article 17, Article 15. Every articles of FCTC are part of this health promotion agenda of this plan to tackle non-communicable disease. Important to highlight that Article 19 was as well included in this. 19 has to be with liability, with civil responsibility of tobacco industry by the damage caused by tobacco use. And also, we included Article 5.3, protecting the implementation of FCTC from tobacco industry interference. And it's important to highlight here that there was a trend in this plan to negotiate with private sectors, including the food industry, in order to decrease the content of sodium in the foods. But we highlight that there is no chance of agreement with tobacco industry because we are committed with Article 5.3. So it was very important to put this on to avoid any misinterpretation that we could negotiate with tobacco industry as well. So this plan has also agreed indicator for tobacco that was to reduce the smoking prevalence over the population 18 years old. Here we can see the projection that was made considering the decrease that we have been achieving in the past years. And our goal was to have an annual decrease of 0.5% in smoking prevalence in Brazil in this plan. And what happened that in 2000, we can see here the results of an annual surveillance survey that is done every year by phone in the main capitals, Vigitel, from the Ministry of Health. And we can see that from 2006, when this surveillance started, to 2015, the smoking prevalence has decreased from 15.7% to 10.4%, near the goal that we have projected to the 2020. So for us, it was a surprise because we were expecting that we are stopping decrease in some point of this curve. And as well, we had some important impact of these results from tobacco industry, from tobacco control in Brazil. The Lancet in 2011 had made an analysis of the whole picture of NCDs in Brazil and could see that the mortality from NCDs in Brazil had decreased by 20% between 1996 and 2007. And the main fact that could explain this decrease was the control of smoking as a prominent success and responsible for much of the decline in NCDs in Brazil. So this is one of, in short, the picture of this issue in Brazil. Thank you for your attention.
Thank you, Tanya. Thank you, Tanya, and some really good points made there about the multi-sectoral approach and how there are, I think I counted 30 different ministries and sectors involved in that overarching committee. It's a really good success story if you want to have broader collaboration to see what the model is in Brazil. Any questions for Tanya? Everybody is in awe of what Brazil has done.
I'll take one quick question. You mentioned, where'd she go? Okay, it's okay. No, you can. You mentioned, obviously this is a talk about non-communicable diseases, and I was just curious. As I said earlier, I come in from a tuberculosis and HIV background, and there's been lots of suggestions when modeling that if tobacco rates go down, and they've gone down dramatically in Brazil, that this will have an impact, as you saw on the NCDs, that it may also have an impact on infectious diseases. Has anybody looked at that, do you know, to see if that's had a indirect or direct impact on
No, unfortunately, we didn't, you don't have thought on that. It's a good idea to see how we have a plan. The people from National Cancer Institute is working with the tuberculosis control group in order to build capacity building the people that gives attention to the tuberculosis to also have the cessation skills for supporting them. So this is, but we didn't have any baseline data on that, and it's very important.
Well, that was my next question, to see if they're incorporating cessation into TB and HIV services.
We are just making this merge, this cross-cuts.
Great. Another question, right? Next.
No question. Just to emphasize your point, I think it will have an impact on NCD as well as infectious diseases, but then health overall.
Of course.
I think
of course.
Overall, all parameters of health will improve.
Right, and well, she showed a lot that we're already improving.
Yeah. So.
Sorry, it's not really a question. I just think that was the most fantastic result from Brazil, and I don't think enough people know about it. And I just wonder if we can do more in terms of a case study from Brazil on particularly the cross-cutting, because I think a lot of countries are really just stuck at the moment more on dealing individually with their diseases and not making that great leap to the cross-cutting with all of the other frameworks, including the infectious diseases and so on. So I guess this is more a question for Hassan about how do we tell more people about what Brazil has done.
Yeah, I think Brazil is a good model to follow, but what we also need to remember is that before Brazil reached this state, they had laid the foundation of good tobacco control. They had been in the forefront for the health warnings. They were putting enough resources in. And when they had reached that stage, and Tanya, please correct me if I'm wrong, that once they had reached that stage, they started involving the multi-sector approach as well. So you need to do your basics first, the right things in place, and then involve. So if you can't, I think that's the way to go, in my opinion. And yes, we should be highlighting Brazil as much as we can on the way they have approached tobacco control and the way they have led it in Latin America and across the globe. We had a question here from Hassan.
Yeah. Thank you. Very interesting. And wearable, because I've noticed, for example, your Tobacco Control Commission, the statutory body, is not just advisory but executive. It has executive powers. So that's very important, I think. From Eduardo, previous step, you know, we have to always remember the Article 5.3, the interference of the industry. So in this case, I think it will be in a better position to ensure that they don't interfere and they have this executive power. So I'm interested in learning, you know, today's theme, if we look at the WHO always pushing for health in all policies. And when we understand when it comes to tobacco, it has a direct relations also with the other substance abuse like narcotic drugs, alcohol use, and I mean even mental health. So have you been able to, you know, explore that possibility of putting tobacco in the narcotics control, you know, the drug control programs? And one additional question is, another interesting one you mentioned is Article 5.3 and other important articles being in the Civil Service Act, which in effect means all civil servants are also bound by this. So how were you able to include this in the Civil Service Act? Thank you. Civil Service Act. Civil servants. You put in the presentation there was the Civil Service Act. Yeah, I think for the government, this is the one that governs the behavior of government employees, right? So you said it is by policy, it is mandatory for all the departments to implement FCTC. And since you have a specific law, legislation that governs the behavior, the conduct of the civil servants, I think that's very important. But I'm just question is, how were you able to put FCTC in that? I mean, that's very, very interesting.
Regarding the first question, the issue of merging tobacco within other drugs, program control, alcohol and other drugs, we didn't succeed it yet, but we have been working with them in some symposiums. Tobacco is there, but we don't work, for example, we don't care with this, in this issue, but we have some relationship with people that use with alcohol and other drugs. We have some different thoughts from people, because people that deals with drugs and alcohol, they have already, we have been discussing a lot on the issue of harm reduction. We have some criticize for that we don't work with harm reduction in tobacco control. So we have some divergent views, but in some points we agree and we work together. We tried to put tobacco control as a cross-cut agenda, but we have this not well-resolved point of the harm reduction approach that we don't have in our national policy. Maybe in the future, you don't know. We are open to hear what's the idea, but for this momentum, we don't have so close relationship with this issue of alcohol and other drugs. Regarding how, let me see if I understood. You are meaning the issue of how to put the health offices, to put tobacco control in health offices in states and municipalities, or no? Oh yeah. This is was motivated by FCTC agenda. When we finished the negotiation process of FCTC, someone from the National Commission that was advising the process, that was not so keen of tobacco, of FCTC, from someone from Ministry of Agriculture, you know why in Brazil, said, okay, now the Commission should not exist anymore because the process of negotiation has finished. So we very very slowly and very silently, we went to the Minister of Health and said, now we need to transform this commission that we have finished the negotiation in an executive commission, because it was created by a president decree. We need to transform the president decree to transform this commission in an executive commission. So we prepared the draft of this decree, and it was published, and very surprisingly published. So it was the way we found to bypass tobacco industry indirect interference on this process. And then with this document that empower us to say, okay, we have an obligation, the Minister of Health as president of this commission send letters to the minister that has obligation with implementation of FCTC, to call them, to indicate someone to represent this minister in this national commission. We have already prepared some guidelines that's official published to deal with Article 5.3, to guide how these officials has to deal with tobacco industry relationship. Because we know that tobacco industry in Brazil is a legal company, is a legal industry. Some sectors need to have some interface with them, because, for example, the Minister of Development, Minister of External of Trade, Foreign Trade, needs to have some relation with them because we export tobacco, unfortunately. So we need to put the rules how to deal with them. So we have formal publication that was discussed into the commission, and we have formally how they have to behave when dealing with tobacco industry, following Article 5.3. So it was a process. The needs make us going step by step and building all this whole process.
Thank you, Tanya. And I think another important takeaway from the presentation was that it's a state program, not a government program. Governments come and go, but the state stays there. So that's really good. Bill, can you hold on to your question for the end discussion, please? So let's move on to the next speaker, who's our guest, Paraje? Yeah. From Chile. He's associated with one of the universities there, and he's going to present on a very interesting topic, and with a little help from BAT, effect on prices, bans, and smoking onset in Chile.
Okay. Thank you very much for the invitation and the opportunity to come to Liverpool to present this. I'm going to present a pure economics study from Chile, with data from Chile. Unfortunately, Chile is not Chile's development in tobacco consumption is not as impressive as Brazil. Chile is one of the countries with the highest smoking prevalences in the Americas, and one of the highest in the world. For 15 and older, especially for women, in 2013 was 41% among males and 37% among females. There is a specific age group for females which goes from 12 to 15 or 13 to 15 that has one of the highest prevalences in the world. One of the most important legal changes only happened in 2006. I'm going to show a bit later the chronology of the changes in legislation and tobacco taxes. But basically, this legislation, among other things, included a general advertisement and sales restrictions, and was aimed particularly at youth consumption. It included a smoking ban at schools and the prohibition of selling tobacco within 300 meters of any any school. So apart from that legislation, which was the law 2105, Chile has been very slowly moving towards a bit more aggressive legislation on tobacco control. The latest one in 2013 included a total ban on tobacco advertisement, increased the number of warnings, and it also included a total ban on indirect advertisement. We also have been increasing more recently, a bit more rapidly, tobacco taxes. In 2010, the ad valorem tax was increased to 62.3%, and a very small specific tax, excise tax, was included. Now, this was later changed in 2012. The tobacco tax, specific tax, was increased. And in 2014, I'm not showing it because the study doesn't include 2014. Basically, the ad valorem tax was decreased by half, but the specific tax was substantially increased. So now we are going towards a correct design of the tax policy, basically only based on specific taxes. The tax burden on tobacco has increased due to these changes. But if you can see, between 1998 and 2010, basically there were no changes in taxes, in tobacco taxes, and that will be important when I show prices. Just to compare Chile and Brazil, we are again moving towards a more aggressive legislation. Now the Congress is discussing, and it has the approval of the Senate, of the upper house, and that is going to the lower chamber of Congress, which will be hardly fought. A law that basically prohibits also additives on tobacco and implements plain packaging, which is really, really, it will be really fought by the industry. It's already being fought. So if you see the changes in prices, in real tobacco prices between 1979 and 2013, basically what you see is that by the end of the 20th century until 2010, where this vertical line is, real prices have been increasing. But there were no taxes there. There was no tax increase. So really, the increase in price, the middle, just before the vertical line, was mainly driven by VAT, which has 95% of the market in Chile. So what basically they were doing is that because they already had a mature market, a very high prevalence, they were increasing the prices to increase revenues. After 2010, prices have also been going up, but this time mainly because of taxes. Still, the pass-through of the taxes, which is how much of the tax increase goes to prices, is lower than the tax increase. So still, VAT pricing policy means that they are being taxed more, but they pass the price more to consumers than they say, which is very important because of all the claims they do about, for instance, illegal trade, contraband. Basically, the automatic Pavlovian reflex of the tobacco industry is to say that tax increases lead to contraband, which is basically hard to believe. At least it's hard to believe that they are worried about that when they are the ones, at least in Chile, which are mainly behind price increases. So, I mean, contrabands are related to prices, not to taxes. Yeah. So if you increase prices more than the taxes, it's because you are not that worried about contraband. There is a previous study done for Chile on the topic basically that I address, which is one of the topics I address, which is the impact of the 2006 ban on smoke at schools. It was published last year in the bulletin of WHO, and this uses an uninterrupted time series approach. And basically, what they find is that 5 to 6 years after enforcing the law, the 2006 law, the smoking prevalence among high school students was almost 14% lower as a result of the ban. So basically, they claim that the ban was effective in decreasing smoking prevalence among school children. Now, the big problem, the big limitation of this paper is that they don't consider prices. So basically, they assign most of all of the effect of changing attitudes in school children to the ban and not to prices. And if you see, if you remember the graph I just shown, the prices increased basically 60% between 2005 and 2011. So it is hard to believe that prices didn't have any effect on children and smoking. So my research question, which I answer in a different way than this study, is basically what are the relationship between the ban on school smoking and prices on tobacco initiation. So I'm not looking at tobacco prevalence, but tobacco initiation. So how the ban and these higher prices prevented initiation on school children. What I use is, this is the only formula I have in the presentations. What I use basically is a statistical model between the risk of onset and individual and non-individual variables. I say that the risk of smoking, which is the variable age, basically depends on individual characteristics that may or not depend on calendar time. It's a usual survival duration model. And also, depends on some time at risk. So the risk, and I also say that the risk of smoking depends on non-individual variables that may vary with time, and there we include real prices, real tobacco prices. So basically, what we say is that, or what we see from our sample is that this is basically the pattern of risk of initiation for school children in Chile. We basically pulled several surveys, I'm going to talk about this a bit later, from 2001 to 2013. Basically what it says, this graph, is that the maximum risk of initiation is around the age of 16, 17. If you don't initiate by 16 or 17, basically the risk of smoking decreases very much. Surprisingly, and this is really, really peculiar for Chile, the risk of initiation is higher for females than for males. You know, basically, in most of the countries, males have a higher prevalence and a higher risk of initiation. Chile is quite special in this respect. So basically, if you have that, your health policy, and I include taxes in health policy, which is not very liked in the Ministry of Finance area, but taxes on tobacco are part of health policy, has two effects that are very important. The first effect is basically it decreases consumption. The other effect is either it deters people from starting or delays initiation. And that delayed initiation basically could decrease substantially the risk of initiation. So if prices are good for delaying initiation, basically they are achieving one of the goals of that policy. So the data I used is a school population use of drug survey that is consistently done in Chile with the same questionnaires, with a similar sample, and it is conducted every 2 years, and I used 2001, 2003, 5, 7, 9, 11, and 13. The surveys are representative at the national level and at the regional level, and they basically sample children from 12 to 17. Of course, in the sample have older children because of repetition, but basically that's the main population. So since the last year of primary school to the last year of secondary school. So my sample is about 63,000 students from several types of schools, from public schools, which are children from the poorest backgrounds, public subsidized schools, which are basically middle-class children, and private schools, which are better off children. These are some descriptive statistics. I would like you just to look at the first row, which is the age of starting smoking in Chile, extremely low. In 2001, it was, on average, almost 13 years. So the average children would start at 13 years. And by 2013, that age was only moderately increased to 13.5 years. So we used several models, several specifications. We modeled time and time at risk by different ways, using a quadratic polynomial function, using a very flexible dummy approach, with dummies for each year at risk. And basically what we found consistently and very robustly in all the models is that basically onset elasticities are around minus 1.4, which basically means that if you increase by 10% the real tobacco price, the risk of initiation decreased by 14%, yeah, which is quite a lot. Yeah? We have had 60% of real increase in tobacco prices. So basically, we should, of course, the elasticities cannot be taken linearly because they change as long as you change prices. But basically, what the sample says is that the sensitivity to changing prices of initiation is like this. Now, unlike most of the countries, girls in Chile are less sensitive than boys to changes in prices. Those still are very sensitive. Basically, the elasticity is minus 1.3. And regarding the ban, when we control for everything else, for even for prices, we found that the ban was effective, was less effective than the other study claims. But basically, what we found is that the risk of initiation is decreased by 0.2 because of the ban, and the results are significant and are robust to all model specifications. So my conclusions, it is hard to compare these results to other developing countries because basically there are not many studies looking at initiation and prices in developing countries. In Latin America there is none. Basically this is one of the first one. And basically what we found is that prices are very effective at decreasing actual consumption, and we have also studies on general population regarding elasticities of actual consumption, but also they are very effective at decreasing initiation, which is something that we want. We don't want people that smoke to decrease smoking, to decrease its intensity, but I think, should be our main, or one of our main objectives is to stop children to initiate smoking. So the elasticities involved in Chile are relatively high with compared to even developed countries, which indicates that the policy is very effective. Of course, I showed you that the main driving force behind the price increases have been industrial pricing policy, which is something that also has to be taken into account when we discuss public policies and when we discuss issues like, for instance, illicit trade. And non-price policies such as these bans and these smoking bans at school, or the prohibition of selling tobacco close to schools, are also very effective and can play and should play an important role in this policy, in the aim of decreasing risk of initiation in the youth population. Thank you very much.
Thank you, Dr. Pahe. In terms of time management, before I open the floor to questions, do we have Mr. Sharma from India for the next presentation? So, Bakul, you're here. Any other presenters during the session? Because I think the IT people are saying there are only 3 presenters who have uploaded their presentations. So, Nandita, anybody else who is presenting during this? Okay, good. Then we have lots of time. So I'm sorry, Bill, that I stopped you earlier. We had more time than I anticipated. So let's go open the floor to questions. We got one here from Dr. Jackson.
Thank you. That was a really excellent presentation. I think a lovely illustration of the power of tax. I was really struck by that. I was also struck, and it's probably not the right question to an economist, but what do we know about why the age of initiation for girls in Chile is so low, given that they're not as sensitive as boys to price? Do they know what other factors are?
Thank you for the question. You're right, it's not the right question for economics. No, what we know is that there is an increasing participation of women in every aspect of Chilean society, and smoking is one of them. I mean, this is kind of a sign of, you know, yeah, and yes, but also there is a deliberate targeting of girls. I mean, with flavors and with well, not ads now because they are forbidden, but because of basically ads. So there is a, you know, deliberate targeting of girls. Now, it is true that girls are not as sensitive as boys, but they are still very sensitive to prices, very sensitive. Yeah.
Did you partial out what was the effect of bans as opposed to tax increase or price increase? Do you know which was more powerful? You did mention that the bans had a real good effect on on the young people, and the price increase was also very effective. Were you able to partial out both? And
Yes.
uh-huh.
Yes, of course, the effect of prices, I mean, when you estimate this, you're basically estimating a point estimate for elasticities, yeah? So the effect of prices will depend not only on the point estimate, but also by the increase in real prices. But comparing this point estimate to the effect of the ban, the effect of prices are more important. So basically, at least in this study and in this case, it is still true that prices are the most effective policy to decrease consumption or initiation.
It is consistent with the rest of the globe.
Yes, yes.
And you mentioned that the price is going up mostly because of the industry
Yes.
increasing the prices and not the taxes. So
Yes.
the industry themselves are actually lowering the initiation by children.
Yes. But you saw the figures, they didn't lower it too
Enough,
much.
Too much.
Still, I mean, we are talking about
And by increasing the price, they're still
yes,
making that back up.
we are talking about even when for children is a bit different, but we are talking about an inelastic good, which means basically that you increase prices and your demand decreases, but by a lower proportion than you increase taxes. And that means that you increase prices and you increase revenues.
So the children and that,
Exactly.
right, optimal. Can I just ask one question? In Chile, so the children, 14, 15-year-old kids who are initiating smoking, are they going and buying their own packs of cigarettes, or are they really getting them from somewhere else?
The law, it is illegal to sell cigarettes to minors.
Okay.
They can get it by their own in shops that don't respect that ban, or they can get it from adults. But it's illegal to sell tobacco to minors. Now, the enforcement of that law is difficult because again it's always the same. I mean the Ministry of Health, which has to enforce that, doesn't have enough people.
So we got one question at the back and then Tanya in the front. So.
I think this is a really great study because we've all looked at decreases in consumption from prices, but not very little on stopping people starting. So I think this is an excellent contribution. I was wondering, if not from the model, but just your observation of the data, were you able to, can you make any statements about the slowing of the initiation? Rather than just, moving it forward a couple of years.
Thank you. I have to do that. It's an excellent question. No, look, I actually have to estimate, because what we have done is just to measure by how much decreases the risk, so how much this hazard curve moves down when you increase prices by a certain percentage. Now, what I have to estimate is, which is the same, basically, it's another way of answering the question, by how much you postpone initiation for those who eventually initiate. But it's true, I mean, that's the last bit I need.
It's a very, very interesting study, and I'm very, very impressed with the issue of the girl, the gender, the sensitivity of gender in Chile. It's very concerning from our gender view. I'd like just to ask you something regarding the level of income of this group. Did the model catch the difference of the elasticity between comparing low-income groups with high-income groups? Could you succeed with that?
Yes, we used, we don't have incomes because the surveys are done on school children, with school children. But we have two indicators. First is the type of school, if they are public, publicly subsidized, or private, which is an indicator of socioeconomic level. And we have mother's education, which as usual is a very useful way of, yeah. And what we found is that, as economists would say, poorer children have a higher sensitivity to prices. Poorer measuring in both ways. I mean, not together, but we used models using one or the other, and we found that children that have a lower SES are more sensitive to prices, which is again something that you could expect.
And
I might have missed this, but were you able to look at the children's exposure to tobacco advertising that sometimes is included in a national survey of school students and also included in GATS? You know, where are they seeing their advertising and inducement to smoke? Were you able to look at that?
No, because we don't have that variable in the survey. But in November, it's coming out a special number in the PAHO journal on tobacco. And no, sorry, no, no. There will be an article published in Salud Pública de México with Emmanuel Guindon and another colleague, where we used GYTS. And for 10 South American countries, basically, we measure the effect of advertisement on tobacco consumption. So, not in the study, there is another one coming.
What some other countries do with this sort of, you know, where do you go from here? And what some other countries have done with this sort of information from research is they estimate then how much those children are contributing to government revenue from smoking. And so, you know, the tax they're paying. And then they use that as part of their rationale for why government should spend more on reducing smoking rates and so on. So I don't know whether you're going to do longitudinal studies from now on to keep this going, or whether you're going to try and use it as part of the rationale for another tax increase, a better tax increase, and using some of that money for sustainable funding for tobacco control, sort of, you know, linking up all the issues.
Yes, this is not a longitudinal cohort, so we cannot do longitudinal, but of course we can add surveys and check how it is changing over time. Of course, we are using this to ask for more, for increase in taxes, these and other studies. Unfortunately, in the case of Chile, we cannot earmark tobacco taxes revenues to tobacco control. That is not possible because of the Constitution. But again, we have costs not for children, but for the general population, of how much it costs in direct cost, the tobacco consumption in Chile, and so we compare that to the amount the government gets in revenues. Basically, the government doesn't get more than 60% of the direct cost on the health system of the tobacco consumption. So we are using several types of study to advance.
Thank you
taxes.
very much for a very interesting presentation. Let's move on to our next speaker. The states in India have been legislating at the state level against the tobacco use and putting some very good policies to stop the increase of tobacco consumption at the state level. We are glad that Mr. Sharma is here from Madhya Pradesh, who's going to present on his state's experience on what they are doing for major policy and what the analyses are. Bakul, up to you.
Thank you very much, sir. I'm basically going to present whatever the major policy decisions that have been taken and what is the trend of tobacco epidemic in the state of Madhya Pradesh. As you can see the photographs, this photograph shows the population density of our state, that is around 70 million. So in order to save the lives of 70 million, whatever good thing that has even happened that I just want to share with you. Just in order to understand the tobacco control intervention, and analysis of the major policy level intervention was done, and this has been linked to the survey conducted by the government of India, that is National Family and Health Survey. So the data of that has been linked with the policy level interventions. As far as this NFHS is concerned, NFHS is one of the most comprehensive survey done by the government of India, and it was started in 1992-93, and till now 4 rounds of this survey has been conducted, and in 2005 and 6th, 3rd round, and in 2015, 4th round was conducted. So it is not a comprehensive survey on tobacco control basically. It deals with all the health aspects, child mortality, maternal mortality, but some questions related to tobacco control are also included in the survey. So as far as the policy analysis was concerned, in order to understand the whatever implications of the policy and whatever good thing that has been happened, I just analyzed some state level orders that have been passed. Like in the state of Madhya Pradesh from 2009 onwards, various tobacco control interventions have been done. And from top level to bottom level, government has issued various orders to district collectors, to chief medical and health officers, and to enforcement officers regarding tobacco control. It is related to the implementation of Tobacco Control Act, as well as also regarding the comprehensive tobacco control community outreach activities. So a lot of orders have been passed. As well as I also analyzed various types of media clippings. Whatever orders or whatever that is good things happened in the state of Madhya Pradesh have been widely publicized in the media. So the media clippings were also analyzed in order to see what has happened in the state. As well as government websites were analyzed, the health department websites, as well as the public relation department website. This is the most important thing, that whatever good thing that has happened in the government, it is passed to media through public relations department. So it means that government involvement was much more. The media was made aware by the public relation department of the Madhya Pradesh, of the state. And I just wanted to share that one good thing that has happened, that the Chief Minister of Madhya Pradesh has taken initiative for enforcement. Although he is not a designated authority, but when he was visiting a particular public place, he saw a person smoking in a public place. So he just directed the collectors to enforce law and made a fine of 200 rupees to that particular person. So this media, this news was widely publicized by the public relation department, and it reached all the people of the Madhya Pradesh. As well as a lot of civil society interventions have been done in the state of Madhya Pradesh with the union as well as with the civil society members. So a lot of community outreach activities and various training programs have been conducted. So this also were analyzed. And as far as the tobacco control data was considered, the fact sheet of Madhya Pradesh that is related to National Family and Health Survey was analyzed, and the data was compared. So you can see that the major policy level interventions were done by the government, and one of the most important intervention was the tax increase on the tobacco products. The tax was increased from 13% to 27% VAT on the tobacco products by the state of Madhya Pradesh, as well as gutka, that is a mixture of areca nut and tobacco. Madhya Pradesh state was the first state in India which has banned gutka. So this was a major intervention, and the banning of gutka got a very good media coverage, and it was possible to generate awareness among the people of Madhya Pradesh as well as India. As well as hookah bars. Lot of interventions were done by the civil society members for banning of hookah bars. So the state government, as well as some district collectors in particular cities, they have banned the hookah bars in the cities. Although the hookah bars were banned under the Section 144, that is a legal provision, under Illegal Activities Act, the hookah bars were banned. But this was very effective in generating awareness regarding the ill effects of tobacco among the people. As well as hookah bars in the cities were raided also. And health department, in collaboration with the civil society, have organized various training programs. This was one of the most important component in which the union was involved. A lot of training programs have been organized from state level to district level to block level, in which various officials from education department to health department to the administrative departments were trained, and designated nodal officers were appointed based on their training criteria. As well as the most important thing was the state and district level tobacco control committees. Before interventions, before 2009, there were no state level committees. So with the intervention, with a lot of civil society interventions, the district and state level tobacco control committees were formed, and their meetings were held regularly. At the state level, the meetings were chaired by the principal secretary, as well as at the district level, the meetings were chaired by the district collectors, and civil society members were also involved. So this regular happening of district tobacco control committee has mobilized the administration as well as the department. As far as the enforcement is considered, the Indian Tobacco Control Act was enforced in a much more better way as compared to earlier. A lot of directives were passed. So here you can see the whole trend year-wise. That was the gutka was banned in year 2012. Then hookah ban was there in cities in 2012. Then various orders and directives were passed from 2010 to 2015. And number of DTCC meetings have happened during this period, as well as a lot of capacity building programs happened from 2009 to 2015, and tax increase was there in 2014. Now, as far as the results of the National Family and Health Survey are considered, you can see that the result, the fact sheet of 2015 of NFHS data shows that in 2005 and 6, the women who use any kind of tobacco was 16% in 2005 and 10, and 2015, 15 and 16, it was 10.4%. So it has reduced a lot. As well as men who use any kind of tobacco was 68.5% in 2005 and 6, and it was 59.5% in 2015. So this is a major reduction that has been happened. As well as one of the most important findings of this survey shows that the men who tried to stop smoking or using tobacco within 12 months was 37.2%. That was quite relevant. As well as the woman who tried to stop smoking or using tobacco was 38.5%. So a lot of men and women have tried to stop smoking or using tobacco. And all this has happened because of a lot of awareness and a lot of interventions which have been done by the state of Madhya Pradesh, in which the men as well as women and the tobacco consumers have tried to stop smoking. So that I think that's one of the most positive results that have been shown by this policy level interventions in the state. So in conclusion, I just wanted to tell that the reduction in the tobacco consumption and quitting rates shows that policy level intervention in all these aspects were very effective in reducing the tobacco consumption. Thank you very much. I would just like to thank the union as well as the Union Southeast Asia office to give me this opportunity.
Thank you, Bakul. First of all, Bill has a question.
Well, I was interested in, not dealing with this one, but in terms of the broader health agenda. We know what to do in terms of our tobacco control strategies. FCTC and Empower tells us what works. We've seen it in terms of tax and other strategies. Sometimes our tobacco control strategy might get configured as a cancer strategy. Sometimes it might be in terms of heart disease, depending on what's going on in the country. Latterly, we've got the NCD Global Action Plan. So tobacco control might be taking its place along other NCD strategies. And so I was interested, especially from the first presentation, as to how that pans out. Sometimes those in charge of individual strategies, like tobacco, like alcohol, like physical activity, are worried lest their strategy gets watered down if you've got to go into bed with these other fellows. How's that panned out in reality? How have you dealt in Brazil with embracing the Global Action Plan, the national NCD strategy? And are there any other issues like the Sustainable Development Goals where tobacco has got a place?
Let me see if I can answer this question.
In Brazil, one of the main point to have the sustainability, it was this the point of the question, the sustainability of the tobacco control policy in the, for example, in National Cancer Institute. One of the main aspects was the investment of the National Cancer Institute in putting, building a team, a big team, to manage this relationship that we have with the other key players in tobacco control in Brazil, and building capacity. So this is one of the main aspects that put INCA historically as the leader organization in this process. But this process is not of one institution process. We have to recognize that when we have much more institution on boards, much more other areas of health sharing with us the responsibility of implementing FCTC, the stronger we are. Because we cannot, for example, divide ourselves. We are always facing tobacco industry interference. We have, in spite of having one institution or two institutions, we have to consider everybody as one team. We have to keep in contact all the time, sharing so we have a very good momentum in the global communication. We have social media, we have WhatsApp, we have, so we are always talking to everybody when we have, so this is very important aspect. It is not an institution issue, it's a network issue. So this is our view of the process, so we understand that if we viewing that like this, we are much more stronger. So I don't know if was the point that you raised. I didn't know if I catch the main point, but I'd like just to pass this message because when we are together working with civil society, we are considered as only one team. So it's very important for us to face the difficulties we have with money. We don't have money, for example, for making nationwide campaigns in TV. Because it's very expensive in Brazil. Tobacco industry has, but we don't have. But we network. We work in sharing the information. We don't keep the information for us. It's important for our partners to have the same information, to speak the same words, have the same, share the same view of the process. So this is how we think, and I think that's for us, it's one of our main important issues.
Thank you, Tanya. Any questions for a friend from Madhya Pradesh? So I'll just open the floor on the presentation as well.
Yeah, I think that success, the way he has mentioned in his presentation, there's a lot of players there. I think that's the key, getting involved. And I'm interested in learning, while all this happened, what was the tobacco industry doing? You know, didn't they try to disrupt the process? You know, like, for example, there are these front groups now very strong for shisha or hookah, and don't you have those in your state? That's.
Basically, the major thing that was done, that was against these hookah bars, because a lot of local businessmen were involved. So they have tried to stop this, and they have tried to interfere in the process. They have filed some litigation also. But because of the commitment by the district administration of the state government, that has not been happened, and their efforts were not possible. But as far as other things were considered, there was not much thing that has been done by tobacco industry as such directly. Behind the scenes, they may have done, but directly that was not shown. Although the advertisements and all this that was related to pan masala and were there, lot of advertisements were there, but not much thing that has been done directly by the tobacco industry, in spite of this hookah bans. Yeah. That was gutka ban that has been happened. That was that's what you're calling about. Okay, okay. That was possible because a lot of stakeholders' involvement in this the whole process, as well as the sensitization of basically the ministers, the chief ministers, MPs and MLAs that was there by the civil society regarding the epidemic and its whole the number of lives that have been lost. So because of the sensitization of the local ministers as well as the chief ministers, that was possible, as well as some at bureaucratic level also. The officers were much more were keen to ban it because by looking at the epidemic part of this. So the civil society were able to sensitize the basically the implementers as well as the elected leaders. That's what was there.
And just to add to that, Hassan, it was a multi-stakeholder approach. The government of India was concerned about environmental pollution, so they banned all plastic bags, all plastic packaging, and gutka was traditionally packed in plastic. So when that plastic ban came in, gutka couldn't be packaged in anything. So the tobacco control advocates jumped on that law and full food safety law.
Safety, yeah, food act.
And then gutka was also banned. So the states took on. So again, a very good example of using the existing laws in environment, social laws, others, in furthering the progress on tobacco control. So that was done in India. But Miraji, this is right that the environmental laws came into play first, and then the gutka ban came.
In addition to that, enforcement was very good.
Yeah.
A lot of enforcement were done at the state level.
Talking about that the multi-sectoral implications were there, the involvement of all the sectors were there. That's why he's talking about the commitment of the administration, the political commitment, and then all the other sectors. And that is what. I mean, not that the tobacco industry didn't come. We have cases being fought in India, and it is only very recent that we got a victory on the tobacco.
I can see a lot of people from other countries as well. So this is a question for the floor, not to the speakers directly. That have you experienced any issues on, as Bill said, diluting of tobacco control efforts, because tobacco control is 1 in 139 indicators of the SDGs, or tobacco control has now been put under NCDs and is one of the 4 factors, different companies coming in, different other big food, big tobacco, big alcohol, all coming in. So any experience from some of the other countries in the room? I can see Philippines, China, Bangladesh, Vietnam. So a lot of countries represented here. US, Brazil, India, New Zealand. I can see New Zealand as well. I can see Eastern Europe. So before I start taking names, somebody wants to take the floor on this question? Yeah, Anne?
No, I think this has been a very good session about the role of multi-sectoral collaboration and also, setting a good research agenda for tobacco control, because we need both those things. Coming back to, the broader health agenda, I think there's a lot of lessons to be learnt, from the multi-sectoral collaboration and the research setting agenda that we really, it's a bit of a blank space, I think for a lot of us. We haven't really mapped out how we are going to, work tobacco control into the broader health agenda and how we're going to balance all those things. But I think we've learnt, we've heard today about the important role of multi-sectoral collaboration. So it's not really a question, but just a sort of statement about the what I think we've seen today in this session, and how important it is to set the research agenda. But I think that's a really critical issue, that's a collaborative process, so that the most important things that need to be done are being done.
You got Tanya next here.
I'd like just to share a little on how indirectly the tobacco FCTC came into the rural development agenda of Brazil. As Brazil is a big tobacco producer, is the second largest tobacco producer and the largest exporter, we had to deal with this situation of having 100, when we ratified FTC, we had almost 200,000 farming families, small farming families engaged in tobacco production by big tobacco companies. So one of the conditions for Brazil ratify FCTC, we passed 2 years fighting inside of the National Congress to ratify FCTC. And one of the conditions was that Brazil should have a national program to provide alternative to tobacco livelihoods. It was we say that the tobacco industry gave a shout in their foot because they put these difficulties for us to ratify, and the result was that. So the Ministry of Agrarian Development in Brazil that deals with family farming, the rural development, assumed this role to put in place a national program for diversification in tobacco growing areas. This program is not a new program. It's an action that is included in the frame of rural development. And this has to do as well with the food security action in Brazil, the food security policy in Brazil. So indirectly, this program has somehow take some, not so much family, but because it's a very difficult process, it's a very slow process. We have tobacco industry putting all obstacles as possible. But this program engaged these farming families that are stopping producing tobacco to produce other foods, kind of foods, to sell their production to the government food purchase that is part of the food security policy. So this is an indirect process of how FCTC has been entering in this process of food security and tackling poverty.
So you considered this before ratification?
Yeah, when we tried to ratify, we have, for example, tobacco industry started to say that if we ratify the FCTC, we would cause economical chaos in tobacco producer regions, and we are taking out the livelihoods of tobacco growers because they use tobacco growers as a mass maneuver. They don't care with tobacco growers. They use tobacco growers to press the government. So it was an opportunity for us to know better this reality, to visit the regions. We have 5 public hearings. The Senate of Brazil organized 5 public hearings in these tobacco growing regions. We went there. The tobacco growers were very frightened because they thought that FCTC would take them, prohibit them to produce tobacco. The tobacco industry told this lie for them. And so we have to engage with organizations that were there working with tobacco rural area developments, and so they engaged defending FCTC, and now they are one of our partners in Brazil to
This is really far-sightedness, because I don't think any of the countries before ratification thought of all these immense big problem which are going to prop up in the future. And that is why, ratification was so quick. Everybody was ratifying without realizing, the ramification. And here is Brazil, who was considering what is going to happen to the livelihood. And it is now only in our country, at our door, the farmers are at our door, during the COP, there is going to be a lot of noise being made by the farmers and others, and
It always pays to plan
yeah.
ahead.
So this is not, this is so unwise not to think of it before the ratification. And
Yeah.
here is
So
Brazil.
we've got one more question
Yeah.
from Marika at the back.
Thank you. Very interesting, the multi-sectoral approach, particularly probably if you're engaging also the co-equal of governments. And I'm quite interested on how you are able to get some of your government agencies who are directly in conflict with health, like let us say for the trade and industry, and as well as in the country, we have the agriculture department, which is probably quite similar to your agrarian. But under the agriculture department in the country, we have the National Tobacco Administration, which is directly in taking care of the tobacco farmers. And they, by themselves, they do not want to engage in anything outside of tobacco farming. So my question is how the approach that you made in order to get these agencies who are in conflict with that of health to accept FCTC. That is, of course, in the presence of tobacco industry interference as well.
Tanya, we almost running out of time, so a quick response would be really appreciated.
Yeah, it's difficult to say this history in but I will try to. We have in Brazil two big ministers that deals with agriculture. We have the Minister of Agriculture that deals with agribusiness, and we have the Minister of Agrarian Development that deals with family farming to promote to tackle poverty in rural areas. So this Minister of Agriculture is very difficult to deal with them. They are part of FCTC, but they are very keen with the partnership. We had the China tobacco session, and they are very keen to have a China tobacco monopoly in Brazil, engaging 1,500 farming tobacco growers to produce tobacco. They are very happy because we have BAT, Philip Morris, Japan Tobacco there producing tobacco in Brazil, promoting the tobacco production. So we have some difficulties inside of the National Commission. And just very fast, one of the main points that we have in Brazil that is not easy to deal with that is that because the ministries comes from the legislative power, from the National Congress. There is a negotiation. And most of the ministers of agriculture come from tobacco growing areas. So they are there to, so it's very difficult. We have the Minister of Foreign Trade that is also supportive of tobacco growing, tobacco exportation. So it's not an easy process. But you have a lot of ministries that support FCTC. So we are always with the, say, okay, this is a state, it's not a government, it's a state policy. You need to converge your policy toward FCTC objectives. So we have the evidence, we have the power to say, but it's not an easy process, but it's something that is emotional to see, to work, because we always trying to have these people on board, but it's not an easy process.
Thank you very much. We were supposed to have 8 presentations today. We had 3, and we lasted the entire time, which just goes to show how much there really is to talk about with this subject. And I think that we should remember that next year for the next meeting to plan accordingly to potentially allow for fewer presentations and quite a bit of discussion like this, which was very rich. I learned quite a bit from it. So thank you all for coming, and this concludes the session. Thank you.